All right, let me convene us all. Thank you all for coming. For those who I don't know, I'm Sandro Galea. I have the privilege of serving as Dean of the School of Public Health here at Boston University. This is our Public Health Forum, which is our monthly premier academic event of our calendar. And this is our first Public Health Forum of 2017. Right, 2017, I keep getting the date wrong, but continuing our 2016-17 series. And we are truly delighted today to have with us Professor Shiriki Kumanyika, who has for a long time been one of my heroes, who has been able to combine excellence in scholarship as well as excellence in action. Let me just give you a thumbnail about Shiriki. So Dr. Kumanyika is currently an emeritus professor of epidemiology in the Department of Biostatistics and Epidemiology at the Pennsylvania Perelman School of Medicine. She's also currently at Drexel, a research professor at Drexel University School of Public Health. Dr. Kumanyika has a really interdisciplinary background with degrees in social work, nutrition, and public health. And for more than 30 years, her research has focused on identifying effective strategies to reduce nutrition-related chronic disease, with a particular focus on achieving health equity among Black Americans. I think Dr. Kumanyika was truly at the cutting edge of all these topics. Today, for those of you who are students in the room, we talk a lot about obesity, we talk a lot about racial ethnic gaps in obesity, but Professor Kumanyika was talking about these when nobody was talking about these issues 20 to 30 years ago. She also founded in 2002 and continues to chair the African American Collaborative Obesity Research Network, ACORN, which is a national network that seeks to improve the quantity, quality, and effective translation of research on weight issues in African American communities. So she has actually taken her work and created what I think is the premier, most important structure to try to bring this work and translate it into real effective, real-life effective efforts that can change how the landscape of chronic disease in this country. Not surprisingly, she frequently serves in advisory boards related to public health and national policy in the US and abroad. She's been a long-time member of the National Academy of Medicine and also was past president of the American Public Health Association. So I think Professor Kumanyika really represents the kind of scholarship and translation that we very much are trying to promote at the school, that in the vernacular of our animating purpose, think, teach, do, she has done a lot of thinking, a lot of teaching, and a lot of doing on multiple aspects. I've admired Dr. Kumanyika for a long time. I've had the privilege of working with her a little bit, and I was delighted when she agreed to do this. Shiriki, thank you for coming.
Well, good afternoon, and I'm delighted to be here and appreciate the very nice introduction from Dean Galea. So I am going to talk about a subject that I've been working on for 30-some years. I started when I was a baby. And there's so many dimensions to this subject and dimensions that I have worked on, but I'm going to discipline myself to stick to the issue of disparities and this global perspective, because that's where I think we need new thinking and new approaches to research and action. So if there will be time for Q&A, and if there are issues that you think I know something about that I don't mention, feel free to ask me questions, but I'm going to try to stick to the script, so to speak. So why is this important from a US perspective? Some points here: the increasing diversity of the US population, the fact that even though the obesity epidemic is population-wide, it is more prevalent in most of the ethnic minority populations. I will not be talking about US, Asian populations. There's a more complex story there in terms of the measurement issues, but the other major ethnic groups have more obesity. Some of the trends over the past decade or so are less favorable, and I'll just show you one slide to make a point about the epidemic not being explained by, or the disparities not being explained by, biological differences. This is just showing cross-culturally populations of African descent in different locations, from West Africa through the Caribbean and to Chicago, a study of Richard Cooper and his group out in Chicago, and this just shows the increasing prevalence to make the point sort of stylistically that this is a environmentally caused or environmentally driven epidemic of obesity, and that the same types of environmental causes that change when people westernized, so to speak, are also some of the things that are changing over time in the population and have resulted in some surprising levels of obesity unequally and inequitably in the population. The disparities are related to social disadvantage, almost by definition. When you see a population is socially disadvantaged, you know that they're going to have more exposure to things that are harmful to health, and that's the case with obesity. We have a good sense of some of the pathways now. We've learned a lot. When I first started working on this back in the 1980s, nobody cared so much because the problem was only in minority groups. And I don't say that cynically, but I mean it wasn't a major population issue, these high levels. And then all of a sudden, the epidemic was in the general population. A lot of solutions were looked at and put into place. And the fear now is that in the rush to solve the problem in the majority population, we might leave some groups behind. There are questions about whether the current solutions that we're putting in place are going to reach groups equally or equitably. And I make that distinction because if the group is behind and you treat them equally, they're not going to catch up. Equitably means you would fix the things that are causing the excess rates, and then you would have a fair solution that would close the gaps. And you'll hear that probably again during this talk. So why take a global perspective on the disparities? I divided it into causes of the problem and causes of the solution. I am at a stage in my career where I'm interested in the right side of the screen. It's not only about deconstructing the causes, but it's in deconstructing the interventions that we're using to see how well they work or don't work in populations that experience disparities. So some of the things that when you see when you take a global perspective, you see a much wider array of ethnic groups in a variety of contexts and with different backgrounds in terms of who they are, how they got there, what their relationship is to the broader context that they're living in. You see different types of economies. Obesity rates vary from Eastern Europe to the more high-income countries. There are income inequalities that obesity is related to. There's more research on socioeconomic status effects, which is going to be a main point of my remarks. And there are, of course, food cultures and activity patterns that differ in, say, other high-income countries in terms of how people get around and what their infrastructure is like. So we learn from variation. So a lot of the causes are the same globally, but the solutions are more local to a country or even to a neighborhood. And you really open up the variability in looking at obesity patterns and inequities when you go globally. In terms of the solutions, there are some things about other countries, and these are my impressions, that I see are having an effect on the way people are talking about obesity. One is the countries that pay for health care look at a problem like widespread population obesity differently. They're looking at populations who need different types of care or more care. There are different policy orientations. You know, some governments are willing to do things top-down. They're willing to provide universal programs, family allowances, and so forth. I put in both columns research on socioeconomic effects because there is a wave of research that I'll be talking about coming mostly from Australia or UK and Europe on the socioeconomic effects of interventions or the effects of interventions according to socioeconomic status. And you get a lot of case studies that give you very rich pictures of different groups, things that have been tried, what works and not, and we're using much more storytelling and learning from cases. And there are some nice cases in various documents about obesity in different situations and the disparities. So I'll now turn to the US data and give you a really quick tour of what the disparities look like, and then I'll give you a couple of slides on the global picture of obesity, and I'll come back to the disparities later. These are the 3 CDC maps that are available showing the proportion of a particular population group that has obesity at BMI 30, and this is for non-Hispanic white adults and for Hispanic adults and for African American adults. So of course on these heat maps, the darker the color, the more obesity there is. To look at the recent data, this is a slide courtesy of Bill Dietz, who used to direct the obesity division at the CDC. And so you can see the trends going up. Now you've heard a lot about we're making progress and we are bending the curve, and that's true. In these very upper years of 2013, 2014, you do see more squiggles or different trends in different groups. But the line at the top is black women who have who are higher in the beginning compared to white women who are down in the yellow solid line, but still perhaps leveling off at a high rate. And then Mexican American women are below that. The white women and the men are in the bottom lines, and you start seeing this movement, and some of that movement in the last couple of years in the data is showing that Mexican American men are going up. I hope you can see that green line, and that black men have gone up in the last decade or so and seem to be leveling off. So the national data don't reveal the fact that while in the general population the prevalence may be 30% in black women, it's 60% at BMI over 30 or 56%. So there are some of these ethnic differences. So at the top of this slide, you see the overall adult data with 40% in women and 35% in men, according to the overall average, including everybody in the population. So that's similar to where the whites were in the last graph. And then you see in children, the rates are about half, 17%, and right now, not different in the boys and the girls, but going up, and there are some age groups in the cross-sectional data where you see some leveling off, but if you break it down further, you will see some trends. I drew this slide from Data in Health United States to illustrate some of those trends. In the left-hand panel, it's 6 to 11-year-olds. In the right-hand panel, it's 12 to 19-year-olds. The top red line in the 6 to 11-year-olds is Mexican American boys, and they're high along with black girls. But what's interesting is that the black boys, who were not really being discussed in terms of childhood obesity, have caught up pretty much with the black girls. And so it's kind of you focus on one group, and then while you're not looking, another group enters the high-risk population. The data in the purple lines at the bottom are for the white boys and girls, and they're it's increased, but right now the boys and girls in that age group are similar, and they're the lowest prevalence. In the adolescents, you can see two groups that are still going up according to these data, and those are the white girls and the Mexican American girls. Again, lower risk groups. Mexican American girls have been typically lower in the data for obesity. The boys have been high, the girls have been low, but they've been going up. And you really wonder, what effects are these, either causal or a lack of solution, that cause these differences in trends by gender and ethnicity? So this is a summary slide using data mostly for African Americans of the factors in physical and economic environments that predispose environmentally to obesity in African Americans. And at the bottom are social cultural factors that may interact or enhance the operation of the economic and physical environment factors. So they're pretty obvious, especially for those of you who've been studying the environmental influences on obesity. In the food area, there are access issues, high access to unhealthy food and low access. And there's also the target marketing of unhealthy foods in physical outdoor ads and so forth, but also in media environments, very clear targeting to African Americans and Latinos, especially children, but also adults. And in physical activity, the opportunities and options for being active outside and so forth are limited. Economically, income factors, economic or financial relationships with companies that sell unhealthy products, who create loyalty to their products by sponsoring concerts and scholarships and rebuilding your community center, as long as they can put their logo up and as long as you become their base in terms of marketing, especially as things like sugar-sweetened beverages are becoming somewhat shunned by other populations. These companies are going to their base and continuing that marketing. School factors in the economic environment and so forth. And then the social cultural factors, which some people think must be the reason, and they start there. I think they're important, different attitudes about body size and cultural food preferences, but they are not, they were there before the epidemic, and you see the rates in all groups have gone up. So they are not protecting, certainly, the populations from increases. So this is a map of prevalence of obesity in adults and children, adults at the top and children at the bottom, just in 2 different periods for the globe. And I'm not expecting you to pick out any particular country from this, but just to see that the same wave of high levels of weight has taken place in across the globe in countries. And the dark shading in North America is what we've just been talking about, but also in Asia and in other countries, a pocket in the Middle East and so forth, and in children as well. And these slides were actually made by AISO, which is now the World Obesity Federation, for a meeting in Qatar, because there is a big concern because of diabetes about obesity in Middle Eastern countries with hot climates where nobody's walking outside. And the McDonald's, as the Minister of Oman said on our panel, McDonald's can deliver up until 2 o'clock in the morning. I think we're just getting home delivery here, but home delivery is other places. So in case you think these are atypical places for an obesity epidemic, they are not. Obesity is there too, and it's quite a concern. And here's some specific countries, just seeing who's, which countries are rising and at what rates, made by Tim Lobstein at the World Obesity Federation. In case you're worried that somebody will outdo us, America's at the top. But there are a lot of other countries, Brazil and Mexico and Saudi Arabia and so forth, for child obesity, where these rates are going up. China's at the bottom, but the rates are going up in China. And so most of the people actually at risk from obesity-related diseases live in places like China or India, where there are huge populations, even though we have higher rates. So I'm making comparisons with high-income countries in terms of disparities. And because I can't show you all the data that are available, I'm just going to summarize some of the key points and then talk about what's being put in place with solution. So we, across different countries, observe higher obesity prevalence in some or all racial ethnic minority populations to different degrees, but we observe that. There are age and gender differences in all of these patterns. In some countries, there's no difference by gender at some ages. In other countries, women seem to be affected by obesity much more. In some countries, depending on how long that population has been there and their circumstances, the obesity, high obesity prevalence predates the general population epidemic, but tends often to track along with the epidemic, as you saw in the US slides. And in immigrant populations, which is another whole topic, immigration itself and obesity, obesity emerges over the generations. Just on the right-hand side, I'm pointing out that these are inequities. The inequalities are sometimes used interchangeably, but inequalities just means that they're different, but these are considered to be inequities in some of the populations, whether there are factors that you wouldn't consider unfair, like cultural practices and so forth, and they're really not inequities. It depends on the country you're in and what the pattern looks like. But in general, there's something that's not available in the environment, or that's too much available, interacting with cultural factors, that is driving a lot of these patterns. The pattern in high-income countries, it's a nutrition transition or a demographic transition phenomenon. It begins first the people who move up the social ladder, economic ladder, and can afford the risk. And then it eventually moves down to the less advantaged populations as the more advantaged begin to move away from the risk. But there's a relationship with income inequalities at whatever level of standard of living in the economy. And I'll just show you one slide for percent of school children with overweight or obesity, again from the World Obesity Federation. And you can see as the Gini coefficient goes up, the prevalence and ecological correlation goes up with the income inequality in that country. And then Tim also drew this for state data in the US to show a similar inequality. The correlation is a little bit smaller, but just to make the point that not only the level of income, but the gap between the rich and the poor seems to be associated with how much obesity there is. And this is socioeconomic status. This is not race or ethnicity. And one of the characteristics of the literature in the rest of the world is that the race and ethnicity have come late to many of the analyses because social class is the variable that people identify from a social policy point of view. But with increasing immigration in Europe and recognizing that it's not only socioeconomic status, there's been more analysis recently, not a lot, but more analyses of racial ethnic differences as well. So let's look at the solutions. This is a page from the website of the World Cancer Research Fund International. It's based in London, and WCRF has become very interested in obesity along with diet and nutrition, physical activity when they discovered during the, I think the 2007 report on diet, nutrition, and cancer, that obesity had emerged as one of the major risk factors for cancer. And so we found ourselves writing a policy report. I'm an advisor to that group that could have been written just as well by the Heart Association or the Diabetes Association of what do we need to do for prevention purposes on a global scale. And Corinna Hawkes, who is a food policy, nutrition policy expert, led their policy initiative in the beginning, and she developed this nourishing framework where it's an acronym for policy solutions. And this slide and the next slide just shows some of the pieces of the puzzle, so to speak, which is a good metaphor because none of these solutions are going to work alone. They have to be, it's a combination, it's a systems problem, it's a combination of interventions, but standardizing label claims in nutrition, changing food marketing, restricting marketing to children, using taxes and subsidies, changing the food that's available in public institutions where you have some control of what's provided, changes in the food supply, reformulation, in terms of, many of these are on salt, but salt and fat and also sugar. Supply chain changes in terms of where what the manufacturers are doing in terms of fruits and vegetables, what's available and where it's flowing, and public campaigns. And so these are just some examples of interventions that have become very important in a paradigm shift globally. So I'll just take a step back. I took the slides out because I was afraid I would dwell on them too much. But the 2004 global strategy from WHO was really the beginning of this recent trend. Before that, it was the Ottawa Charter and some countries showing that you could reduce cardiovascular disease by changing things like edible oil production or big picture things you could do in the community. And so the 2004 global strategy really set the tone for starting to drive change in environments all around the world. And then subsequently, there was the 2011 declaration by prime ministers, not just health ministers, but the declaration at the UN that everybody had to fight non-communicable diseases. And some of you probably already know this, but for WHO to say and for prime ministers to say that even though we have hunger and all other kinds of problems, diabetes and heart disease and hypertension are going to kill our budgets, are going to just drain our health budgets and the ability to cope, and we have to get a handle on it in terms of prevention. And so these policy solutions have come out of that type of paradigm shift. And I'll just comment on a couple of reports that have been especially focused on obesity issues and on the disparities in subpopulations. This is the first one. It is was a commission that was impaneled by Dr. Margaret Chan, who's the outgoing director of WHO. She wanted to make part of her legacy some recommendations for ending childhood obesity. And these are two quotes from the report. The commission was very high level. I participated as a co-chair of the Working Group on Science and Evidence to try to feed information to the commission about what solutions are out there and how well we think they work, so that because they're going to then have this ratified by the World Health Assembly, and so it has to be something that people can be encouraged to invest in. It can't just be some idea of something that sounds good to us. And so they scrutinized everything we gave them in terms of different solutions. But this statement really points out that the commissioners were very worried about subpopulations in the different countries. And they described the picture here that I told you about. In high-income countries, the greatest risks are in the lower socioeconomic groups. This is across the globe. And this is true in low and middle income countries. It will be true in low and middle income countries, although right now it's the higher income who are having the obesity. And then within countries, there are high-risk subgroups. Certain migrant populations and indigenous children are at particularly high risk of becoming obese due to acculturation and poor access to public health information. And it's very important here that the countries that have indigenous populations of color are part of this, and the rates, like American Indians in this country, First Nations in Canada, Aboriginal people in Australia, and Maori in New Zealand, these problems have been seen for a long time before the epidemic, and they're included, as well as the other types of the migrants or people who were not indigenous to the country. So this report really came out with some pretty bold recommendations. One of them, the first one, is promote healthy consumption of healthy food or access to healthy foods. And their list of recommendations includes create an effective tax on sugar-sweetened beverages, which we were, I mean, personally, I was surprised that the commission made such a bold recommendation because there's so much pushback against that kind of recommendation. They also talked about access to foods in neighborhoods where low-income people live. And WHO has had guidelines on restricting marketing to children of unhealthy foods forever, but this commission said implement those guidelines and do something about the cross-border marketing, because access to the internet is high even in the most remote places, and you can't control the advertising that comes across the border. So it was a very, I thought, good report in terms of what they recommended, 5 or 6 different types of recommendations. Just to mention, the target now for diabetes and obesity in the NCD strategy is, where do we want to be by 2025? There's no further increase. The situation is so bad that the target was not, it's going to be reduced by something. It's like, let's hold the line. So this is toward that end by starting in childhood. Another report that has been very informative for me is, and I think is considered one of the best analyses of obesity and inequities, written by Loring and Robertson in Copenhagen, is really analyzing inequities in obesity. This report doesn't deal with race and ethnicity, it deals with socioeconomic inequities. The chart just shows that in every country in the European region, including the higher income countries, there is a gradient with educational level in obesity, highest in the lowest educated and lowest in the highest educated. So the rates go down, as you can see, and they go down to more of like France and Spain, Belgium. Those countries are on the right-hand side of the slide, but in every country you see this gradient, and that's the classical gradient. It does not show up in all the different ethnic groups, but it is the classic gradient. So they were working on this, and these two statements that I pulled out from the report really give their message. If obesity is more prevalent in socially disadvantaged groups, yet the interventions are most effective in advantaged groups, there will be less chance of reducing overall prevalence, and as a result, obesity inequities are likely to widen. So some of this report explicitly talks about first do no harm. If you're going to go out and put in interventions in the whole population, make sure that you're not going to make the problem worse when you do it by doing things that only those who have can benefit from. So in designing interventions, you look which groups have the highest prevalence, which groups are likely to benefit from which strategy, and how can the intervention be crafted to ensure that the groups with the highest need benefit the most. And this, from a life course perspective, they illustrated with this diagram of showing examples of how the problem is cumulative and compounded over the life course. So at the top they have behaviors or situations. The child is conceived by a woman with poor nutritional status, less likely to be breastfed, more time spent watching TV and exposure to advertising, which is true of low income. This could have been written about the US, low income populations, watching more TV. You know, it's an affordable form of entertainment. Fewer options for outdoor play, less encouragement and social support, more likely to gain weight during pregnancy, less likely to breastfeed, more difficulty with health care, less able to get off from work or afford health services. And then you're back to the cycle with less likely to breastfeed and being in poor nutrition. And then some of the reasons for that, workplace policies, chronic stress and so forth, are at the bottom. So I won't, this report is downloadable on the web. I won't read it all, but it's showing how the deck is loaded against people with social disadvantage. So the idea that you have to think about interventions and think about what does it take for this intervention to work? And those of us who've been dealing with this call it intentionality in not hoping that the universal intervention will just trickle down, but really thinking, could this possibly work in people who don't have all the resources that might be implied? And this article, which I've been trying to fully understand, it's out of my field, but the whole area of social welfare policy is very much a part of this discussion. This is the term proportionate universalism. It's been used in the US, John Powell at Berkeley, the targeted universalism. In the US, some people have rejected it because it sounds post-racial. The idea being you look at people's situations and you prescribe the intervention according to their situation, not so much their racial characteristics. So it applies to socioeconomic differences. But looking at this in more depth, the universalism is referring to policies in countries that do have universal services. I mean, sanitation is universal. Some other things are universal. Supposedly, you don't have to pass a means test to get those services. But also, some countries have welfare policies that give some allowances to every family. You might call some of well, even our tax credits, I mean, you have to show a certain level of income or need to get them. But the idea of proportionate means not just giving them more of the same intervention you gave everybody else, but really looking at the quality, type of intervention, and how well it suits that particular population. And this is, I think in the US we usually refer to this as some type of targeting, but I think there's deeper thinking about what targeting actually means and how you look at how this disparity might have arisen what policies do we have in place that actually could impact on that particular pathway, and then applying those to people to make sure that they have some sort of potential for closing the gap. So that's one of the concepts that I've gotten out of reading the literature where this is being discussed more among equity researchers. This is another figure from the Euro report that I redrew to say, the title of the figure is that, you know, it takes a combination of interventions. And the point here, I think, is made very concisely. You need some things that work in the short term. You need to put some long-term things into place. So you need individual solutions, and the example there is access for low-income groups to antenatal care and parenting support. You try to mitigate the short-term the consequences of inequities. But on the other side, you have to work on the long term on the causes of the inequities, and the environmental causes and the causes that reach individuals, so that all these other types of policies fit in. Marketing to children, making healthy food cheaper and easier to obtain, promoting resilience, which is teaching life skills at schools, and reducing social exclusion through community participation. And so I mention this to say that the way people are thinking about this, driven by socioeconomic differences, is deeper and enriched by the fact that it applies to so many different populations in different circumstances. And I found this a much richer literature in terms of thinking about solutions in the obesity field than I have found other places. The group at Deakin in Australia, and a Peters group, is looking to track trends. This is another thing. Track the trends by socioeconomic position. And what these bar graphs show is that the top part is where the trends, where the gap is widening, or where obesity is going up. And what you want to see is that part disappear. You know, where something is increasing, it's increasing, stable, or decreasing. So in high socioeconomic position, you see that it's a smaller group increasing than in the next group, which is low SEP. In the post-2000 studies, when there's been more interventions, you still see differences. The increasing trends are almost disappearing from the high SEP group, but they're still present, even though smaller, in the low SEP group. And then this is showing that these are all children and adolescents. In the adolescents, the widening gaps are seen more than in the younger children. So I would say in the US, the number of papers or studies that I've seen that actually admit that trends differ by socioeconomic status or by race or ethnicity is very small. All the hype has been, we're improving. And you can't even find both race and socioeconomic status broken down. Maybe a sample size issue, but you can't find that very easily in our national data the way it's presented, although there are some analyses done by social epidemiologists and so forth to look at the trends from early childhood longitudinal study and other places. But our policies don't really point us to showing those differences, especially the SES differences. This is another theme and something that I've learned from in the literature. It comes from the group at Deakin University in Melbourne again. This is applying a framework to interventions to analyze their effects on disparities. So the agentic are the ones that require a lot of individual agency. The person has to have resources and be able to comply with the intervention. On the other side, they're the structural, where you're really trying to change the structure to make it easier. And then they're the ones that work by changing the structure, but also sort of helping the person to benefit from what's changed. And the question here was, are the ones that really rely a lot on the agency of the individual going to widen the gaps because people who are socially disadvantaged have less agency in many cases? And the ones that are structural should not likely increase the gradient. They couldn't, this was a literature review to try to develop this framework, they couldn't completely separate the effects on gaps my reading of it is that ultimately the answer is going to have to be in the middle. Nothing that's purely structural is going to work, and nothing that's purely relying on the individual. But if we take the agency out of interventions for low-income populations, we're making a mistake. So I think that this type of framework is useful for analyzing an intervention by how much agency does this require on the individual's part, or does it allow on the individual's part. The third trend is the effort to systematize systematic reviews of equity issues, to formalize that. And this is in the equity field altogether, but they've taken the PRISMA guidelines that are used for the protocols for systematic review, and they've created PRISMA equity, and given these definitions which appear on this slide of what is an equity-focused intervention, so that people have a common language there, a common definition, and then the protocol for how you actually examine that intervention to see if it's working more or less well in socially disadvantaged groups. The result of sub-PRISMA equity reviews by one of the Cochrane groups has looked at interventions in children and adults and drawn conclusions about many interventions that don't seem to be widening gaps. But this literature is still very new, partly because the studies aren't being conducted in ways that you can really analyze them for their equity effects. But the obesity literature is benefiting from this wider interest in really identifying equity effects. And I think these studies, a lot of them are published in the International Journal of Health Equity Research, and the systematic reviewers are a small set of systematic reviewers are getting on board with this approach. So I'd like to end with a few slides that talk about how this has informed my own work on equity. I started doing this with some colleagues in around 2010, looking for data showing whether the minorities were always worse off in high-income countries. There wasn't much information that was broken down by race ethnicity that we could find, but here are the populations that we saw in the literature that had higher rates compared to their host country. So in the Dutch, some of the minorities in the Netherlands, and then the indigenous populations, as I mentioned, in the populations where they live, also Pacific Islanders. So if you have this hypothesis that, okay, this, you're seeing these higher rates, what does it mean and what can you do with it? This is a more recent article, 2011, just showing how complicated it is to tease these things out on different groups. It's comparing, looking at the Dutch advantage of being leaner than the English, and then seeing if the minority groups in those countries shared that advantage. And the answer was no in many cases. And these minority groups are increasing in their proportions in some of the populations. And I saw an article about school segregation, black schools in the Netherlands, and I thought, I don't know if they used to have that problem, but now there's some, areas where people are living, and I think the definition is that when the school becomes more than 50% black, it's a black school, and they have, trying to make policy around that. So these minority issues, racially defined, are becoming issues in a lot of the other countries where they have different populations. And the Dutch have Dutch-speaking populations who live there from their former colonies, as well as other types of immigrants as well. So this is, and I've seen another article looking at Ghanaians in different areas as well. So please don't shut your eyes. I know this is a very busy slide. It's published. You can find it someplace else. I wanted you to see how many different things we came up with. This diagram kept getting bigger and bigger and bigger. Could we get the type any smaller and smaller and smaller? We were trying to make what may ultimately be a systems model for thinking of how do you analyze all the different factors that would go into thinking about an intervention. So I'll just tell you briefly what it is. So we had 4 layers in the middle of this ecological model: the person and their individual, their habitus, of how they are receiving and synthesizing and reacting to their environment. The family, the ethnic minority group itself. Sometimes there's a minority factor of, how does that minority group think about itself? What's their lifestyle? And then what is their relationship with the context of the host country? Is it friendly? Are they trying to assimilate? And all this will vary by individual, of course, but the host country's attitude and experience is going to be different for the minority groups because of that relationship. And then we wanted to look at so these are the settings for intervention. On the left-hand side there are the cultural contextual influences. And we ended up categorizing the types of historical experience. Are people there because of conquest or conflict, migration, economic migration, acculturation, and adaptation? Those are things that would differ across populations. The type of minority: are you indigenous? Are you an established migrant population like African Americans? Been here so long, we should be the same, but we're not. New migrants, and then adding the social disadvantage, because all migrants and minorities are not socially disadvantaged, but many are. And then all the structural influences that we've been talking about, the stratification, the media, and so forth, and then the social cultural influences to take into account. So all of these would be considerations to think about who is that group, and then the intervention targets on the other side at these different levels. And the interventions are things that you would imagine would be relevant at individual, community, and built environment levels. So that's one analysis framework for trying to think how would you go about an analysis of what is happening to a group so that you could predict where you needed to intervene to stop that trajectory where they end up with more obesity and disease. I haven't been able to turn this into a systems analysis, but I have hopes, one day I'll find a colleague who's interested, who knows how to help do that. The other framework I wanted to show you is one that was just released on the National Academy of Medicine website, an idea paper on getting to equity and obesity prevention. This is an infographic just showing all the different ethnic groups and the rates of obesity, and with a comment about why obesity is a health equity issue. But the framework is, it was interesting when I realized that it had a lot of the elements of that one I showed you from the European report. And it's basically making the point that at the top you have health-oriented solutions, the things that we know how to do well in our branch of the field, increasing the healthy options and reducing the deterrents like soda taxes, or reducing deterrents to moving around in neighborhoods, discrimination, feeling like you can't go to that other neighborhood interferes with your physical movement, physical activity. I often give the example of my son who's had cops follow him to our house to say that there was a robbery. Well, how did the police know there was a robbery? But because he saw 2 black kids running. We were living in a middle-class neighborhood, and I said, well, my son came in here. Is that who you're talking about? And there was no robbery, but they just said they better catch the guys first. So these kinds of discrimination, social exclusion, influence physical activity, and so we're trying to reduce those things. You're trying to increase the options, but what does it take for these interventions to work? And then you look below and you see improving social and economic resources, and you see our social welfare programs, legal services, education, job training, tax credits, housing subsidies. And on the right-hand side, you see the capacity building, empowerment aspects. And so I'm going to summarize, and on the final slide, implications, what my conclusion is. So the summary: varied patterns that we can learn from, they're changing over time. If we trace them carefully, we can come up with some clear ideas of the pathways to solutions, where to break the chain of events. The global scholarship on equity issues could really contribute to the intentionality and the sophistication with which we look at these interventions. Many of them point to the integration of social policy and health policy, which is more common in countries with a stronger social pillar than we have. We've never had a national nutrition or obesity reduction plan. I think 70 or 80 countries have made such plans, but we don't necessarily believe here in top-down programming of any type. And then the universalism or universality versus targeting debate. So my last slide is the implications of what I've taken away for the US approaches. That we need intervention packages that incorporate directly policies to address social determinants of health if we're going to have effective and sustainable, equitable solutions. We can't just combine two health interventions and expect them to work. And that sustainable impact is most likely when you could have something in all categories, the increasing options, removing deterrence, increasing resources and capacity, and then working on the agency and the empowerment of the population that you're working with. So this is a theory, but it's supported by the data that we've seen, and it's especially supported by the analyses of people in other countries, other high-income countries that are working on this. So I don't know exactly how we'll get to the next phase, but I invite you to think about the implications of this for our work on obesity prevention so we can get a different outcome because we are putting in different inputs. Thank you. And I'm standing between you and the reception. Okay, good. Yes, thank you.
I wanted to ask what your own perspective is of the growing trend in the U.S. towards promoting SSB taxes, since they are regressive by nature in terms of income, being a sales, well, even if it's an excise tax or a sales tax, ultimately, it costs more money to buy it,
Yeah.
and that's the point. And, I've talked to a lot of people in communities of color in Boston who are very opposed, people working in public health and nutrition and all, who are very opposed to the idea of a sugary drink tax.
Yeah. I don't know if I need this one. I am in favor of SSB taxes based on looking at the evidence for their ultimate effects, and when the taxes are linked to some sort of social benefit for the community. And the example in Philadelphia, when the tax was opposed by the black community, people said they were going to lose their jobs. There's good data that shows that that doesn't happen, actually. These companies keep going. But the health argument wasn't enough to counteract some of the habitual and favorable things and people feeling like something was being taken away from them, although there certainly are other beverage choices. But when the tax was put up the second time and it was linked to some improvements in physical spaces and especially universal pre-K, the community was behind it. And so I think that that question actually gives me a chance to give an example of what I mean by combining solutions, because yes, if you do it only from the health righteous, this is what you should do, and you're not looking at what the community's overall needs are. Communities know how to trade off. So, if they want the thing, they'll pay more for it, or they'll decide not to buy it because they like the trade, and they feel that they want to support policies that actually have the community's interest at heart. So that's my feeling about it. And I don't think they're regressive. There's some pretty good arguments about, they're regressive in the pure economic sense, but that they're not harming communities by making it harder for people to buy, because they might decide not to buy. The SNAP thing is whether they could buy it with SNAP is more controversial. Thanks for your question. Yes.
Thank you. In your first point in your summary, you suggest that direct actions on social determinants would be helpful, and it leads me to think of, I think, one of your previous slides where you suggested combining social policy and health policy.
Mm-hmm.
So are there, I don't think we do that very well, right? We have separate agencies that deal with social policy versus health policies, and in government they don't often talk to each other well, or committees are created to try to go across agencies. Are there examples that you're thinking of maybe that we can learn from where that works well, or that?
Yeah, I think that there's some examples. I can't recite all the details, but CMMI has allowed some pilot programs to use Medicare or Medicaid benefits for social things. Some of the evidence, I think this is a real opportunity for researchers, because if you can prove that providing services to keep somebody out of the ER is going to save you, you know, $10,000, then some of these policymakers begin to listen. So there have been enough of these experiments to convince some of the agencies to do pilot projects. And there's also been this lot of evidence from the other, from the OECD countries, that our ratio of spending on social care and health care is the poorest, and it is one of the reasons why our outcomes, maybe one of the reasons why our outcomes are poor. So the Bradley and Taylor book, I forget what it's called, but it really goes into the fact that even though we may be spending the same total amount of money, the proportion of that that's going to social care is lower, and it's disconnected, as you say. So there's some ways to do that with big policy, but at the local level, it's easier to do that because you can offer services together. You can offer, you know, like in a city health department, or our former mayor created the Department of Health and Opportunity and put different services together under the same deputy. So at the local level, I think is where there's a lot of flexibility for looking at how you get, like when you have people come into a clinic and they sign up for SNAP, but you also show them where they can get a tax credit or they can get something like that from policies that are already in place. Linking it at that on the ground is another way to do it.
So I understand that there's definitely a need for new policies, but do you see a place in this whole problem to use like a positive deviance approach, where you look at what's already working in specific communities despite having various situations, and implementing what's already working for people in the community and kind of expanding it to all?
I think that a positive deviance approach would be good, but for this purpose, not if it had the same effect of training elite athletes in a school where most of the kids don't get any physical activity. So if the positive deviance is related to the way people are resilient in their environment, something that's transferable, I think that's an excellent approach. But if it's not going to be applicable to a larger number of people, because there are always people who can make the most of it, but what resources do they have that make that happen? And those resources you can transfer to other people. That's where I would go. There's nothing wrong with that approach, but it doesn't, it may be more useful in conditions of things other than obesity, in how people are dealing with poverty through like families that survive because they keep their brightest and most competent person out of the workforce to deal with all the other stuff that people have. You know, is that really a solution that you would want to transfer, although some of the family studies show that that's how people cope? So,
I was so moved by the talk, I had developed a coughing fit. But please join me in thanking Professor Kumanyika. Thank you very much.
thank you.